You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way.
This podcast is sponsored by Receptiva Diagnostics. Receptiva Diagnostics is a powerful test that can help detect inflammatory conditions on the uterine lining that might be preventing you from becoming pregnant or staying pregnant. If you have experienced implantation failure or recurrent pregnancy loss, ask your doctor about Receptiva Diagnostics testing. If found, uterine inflammation can be treated, providing a new pathway to achieving a successful pregnancy. Receptiva Diagnostics, because the journey is worth it.
Hello, everyone. This is Dr. Susan Hudson from Texas Fertility Center with another episode of Fertility Docs Uncensored. I am here with my crazy, cunning, and confident co-host, Dr. Carrie Bedient from Fertility Center of Las Vegas.
Eddie.
And Dr. Abby Eblen from Nashville Fertility Center.
Hey, everybody. I hope I'm not the crazy one.
I think we're all a little bit crazy. All right. We also are so excited to have Dr. Sam Ohlander join us today. He is a reproductive urologist, so we'll be talking about everything about sperm at Fertility Centers of Illinois, as well as University of Illinois in Chicago.
All right. Well, thank you guys for having me. I'm hoping that I'm not the crazy one as the urologist here.
You're the unicorn. You're the unicorn.
Thank you. I'll take that.
I feel like all reproductive urologists have a streak of crazy in them because by default, you're always talking about penises and testicles, and then you add a sperm component to them. Like, I feel like there's a special personality that goes to that is always so much fun to talk to and hang around.
You have to be a little bit quirky, right? To do that for a living and have those conversations and such. So, but it's a fun way to live.
Yeah, I would say every reproductive urologist I've been has always been really nice and really funny. So.
Yeah.
Well, we'll see what we can do today. I hope it's a high bar. I've got to get up to.
You gotta represent your peeps.
That's right. That's right.
So, Sam, we were talking before we started recording today, and I understand you've got a battle with rabbits going on.
Yeah, it's pretty serious at this point. I've lived for a really long time in Chicago proper. In the city, there we have rats. But the city is taking care of those, and we're not messing with those too much.
No bunnies there.
Concrete, right? You have concrete. You don't have too much of a yard. I've recently moved out to the suburbs, and we have some plants and things along those lines, and they're just getting mowed down by rabbits. We have a fence. I don't know what to do. I've been purchasing the various products from Home Depot or whatnot, and I just can't keep these things away. And so I've been told that I need to purchase wolf urine. I'm not sure exactly where to get that. I'm intrigued. Again,
you get anything on Amazon.
So,
I bet you can get it on Amazon probably.
Yeah. So that's I think going to be the next step right now because we want to keep them alive and everything like that.
Yeah, we don't want to kill them.
And I even have a dog, and my dog is he's a hunting breed, which in theory you would think that he can smell out these rabbits and scare them away. They will be sitting in the yard. We let him out, and he just kind of stands there.
To make a comment that, in fact, you can buy wolf urine on Amazon.
I told you. I knew.
Well, there you go. How much, though?
How much?
$43 for a 16-ounce spray bottle combo with scent tags. I'm not exactly sure what scent tags are, but I'm guessing this is something that complements the wolf urine.
Yeah, I mean, steep price, though. I know I'm a little bit concerned. There's a spray that I use right now that's fairly strong, like cayenne pepper type smell to it. And that's not very pleasant on the hands. So that one I caught a little burst of wind and it came back at me the other day. So that's one that all of these seem to be a little bit nasty.
There's one that's only $39 and it comes in a big jug. It doesn't say how many ounces it is, but it's Linen Lures. Since 1924.
So they've been using it for that long. Interesting.
Where do you suppose they get all the wolves to get the urine? Because remember how Menotropins were found with nuns in the convent? Like, is there a convent full of wolves where you can collect wolf pee?
Yeah, and how exactly are they getting it? Just not just the animal, but then what's the collection method?
That is a question a urologist would certainly want to think.
I know. In my head, I'm thinking about like condom catheters and catheterizing things. You know.
Wow, poor wolves.
Yeah, exactly. Poor wolves.
I think I would want to be the person responsible for collecting wolf urine.
No.
I'll stick to eggs.
Yeah, we'll keep that to the internet.
We've never given a gift, I don't think, to our guests, but maybe this could be your gift. Maybe in the next few days, a big gallon jug of wolf.
You know, that would be wonderful. At $30 to $40 for a jug. I mean, very much appreciated.
It'll just show up at your front desk in your office. And
yeah.
We'll send it to your office. Can you give us your office address later?
Yeah. You know what? There probably wouldn't even be that many questions. So it'd just be like, oh, it's here. It's here. Yeah.
Oh my gosh.
So good. Well, let's go. Exciting news from Fertility Docs Uncensored. Our long-awaited book, The IVF Blueprint, is now available for purchase. Go now to pre-order your copy to learn everything you need to know about IVF, egg freezing, and embryo transfer. This week, Barnes & Noble Rewards and Premium members get 25% off all pre-orders from July 8th through 11th. Premium members get an additional 10% off. What are you waiting for? Pre-order your copy of the IVF Blueprint now. Let's do a question today. All right. So our question today is, I have found great comfort in your podcast while going through our infertility journey. Thank you so much for listening. We're doing IVF due to low sperm count. My question is, we had 18 eggs retrieved, and of the 18, 6 fertilized. They had done ICSI. I'm wondering what would make the numbers low. I'm 31 and my husband is 37. My estrogen was quite high. I don't want my husband thinking it's his fault, and right now that's how he's feeling.
Well, from my perspective, I think that's really a tricky scenario because I hate when people think it's their fault because there's so much of this that we can't say definitively it's one side or the other side. And the reality is in most situations, it's for whatever reason, probably a combination of both. And so, you hate to hear somebody saying that they're thinking it could be one or another. There's a lot of different factors when I'm thinking from the male perspective. I'm thinking about, is the sperm alive? What sort of motility are they looking at there? You think about certain aspects of sperm quality, thinking about the morphology to a certain degree, though I'll kind of hit on that a little bit later in my thoughts there. I think that there's a lot of different things. I think that just coming in with a short abstinence period, trying to get a real fresh sample, making sure that you're leading up to it with frequent ejaculation. You're trying to live a healthy lifestyle leading up to the specimen collection. I think that those are all different things that you can do to really try to optimize the sample and see if you can improve things.
Sam, I'd like to ask you, you mentioned the short ejaculation period, and that's been a topic that's coming up a lot lately. Okay, no pun intended. And so, exactly,
I really would like to point out, I was not the one who said that.
Die.
This is a bonus.
What do you consider a short ejaculation period?
Yeah.
And who should be doing this? Is this something new that everybody should be doing? Or is it only people who are worried about things like DNA fragmentation? What's your thought on that?
Well, it's one of my general recommendations to patients. When I'm seeing patients, I tell them at baseline, whether they're trying to conceive spontaneously or whether they're going through assisted reproduction, it's healthy to be ejaculating. If you're sitting there trying to build up, I think the common misconception from guys is that they need to build up a really good sample.
Yeah.
And so they'll go for these extended periods of time where they're just going to be getting that older sperm that's going to be starting to degrade. The products of degradation are going to reduce the sperm quality of the sample that's there and everything. So you want to be moving that sperm through the reproductive tract. My general recommendation is around every 2 to 5 days for patients, just as they're living life. However, when they're coming up to a cycle, like an IVF cycle, then I'm telling them to ejaculate the night before and then producing the sample the morning of. Less than 24 hours, ideally. The shorter, the better, to be very honest with you.
So if someone ejaculates, let's say 5 days before their retrieval, or let's not even say that. What if they're one of those people who just went a long period of time and then they get to the night before the retrieval and they're like, oh, oops, totally forgot to do this. They ejaculate, and then they do another ejaculation the next morning. Will that ejaculation from the night before, will that totally clear out everything that was sitting there? Or is there a percentage that's going to remain that's going to still show up in the next ejaculate?
No, they'll probably still have something showing up, but I think that it helps improve things as is, though, too. So every little bit helps in these things. And we can never really predict which sperm is going to be the one that produces success. So even if those instances, I tell guys, don't beat yourself up about these sorts of scenarios. It's what happened. It's the instance that occurred. We're going to do the best things that we can. We've got a lot of tremendous technology that helps us out with in vitro fertilization and ICSI and things. So we're going to do everything that we can on our end. And if we don't necessarily get the outcome that we want, well, we'll regroup, reevaluate, and see what we can do next time.
Carrie and Abby, do you have any other words of advice for our listener?
Well, one thing I thought about, she mentioned that her estrogen level was really high and she got 18 eggs. Sometimes in situations like that, those are patients that have PCOS. And sometimes if the estrogen level gets really high, sometimes we tend to trigger people a little bit earlier than we normally would just because the estrogen level gets so high. And so what happens is a lot of those eggs that we get are undercooked, immature. And so therefore, if it's an immature egg, it's much less likely to fertilize. So it definitely would be worth talking to your doctor about that just to get some sense for how many eggs you really had that were mature that could be actually fertilized with a sperm.
The other thing that you can consider, is there anything that happened in the previous month or so that might be related to lower egg quality? Fevers are the big culprit here. Did you happen to get sick and maybe that was related to it? The other thing is that as much as we all hate to admit this, ovaries are entitled to have a bad day. And a bad day for an ovary is really a bad month. And there are patients where they will go through multiple cycles and their ovaries will perform in some way. And then we'll get some random cycle in the midst of it where it's way better or way worse. And we have no explanation for that whatsoever. And so that's always a component of it as well. And there's a lot that we just don't know, that we can't test for. And so we just smile, take a deep breath, and do it again.
Totally agree. Totally agree. Well, let's talk a little bit about the semen analysis, why it's important. What are some things that are good about it? What are some things we really don't care about, in all honesty, and go from there. So Sam, kind of describe, why do we even do a semen analysis?
Yeah, it's the best test that we have, because it's a semen analysis in of itself. It's not a test of fertility. That alone cannot tell you whether somebody is fertile or infertile, with rare exceptions. Somebody's azoospermic, they have no sperm in the ejaculate, they're going to be infertile. If somebody's sperm is just completely not moving, well, they're not be able to conceive spontaneously or with IUI. So there's certain instances. But otherwise, it just gives us an understanding a little bit of the person's reproductive potential. And so what a semen analysis is and how they established these thresholds was they took this big, large cohort of a whole bunch of different people that, frankly, there's massive areas of geographic bands that weren't included in this, but they took all these guys and they took semen analyses from them, and then they took the bottom 5th percentile. And so it represents the bottom 5th percentile of very specifically a bunch of fertile men. So there's 5% of guys who are below those levels too that did spontaneously conceive as well. And so it's giving us an understanding of somebody's potential to conceive naturally. And then through the course of time, we correlated these things back to intrauterine insemination, in vitro fertilization, so that we can provide the best recommendations that we can to our patients.
I would just like to point out that even if you're in the bottom 5% of your class, Bill Gates and Steve Jobs never finished college. And so just because you show up in that portion of the class doesn't mean that bad things are going to happen. It just means that you are so amazing, you could not possibly conform to everybody else's standards. And so for patients who are listening to this, don't despair. We got hope.
Yeah, there's nothing that says that people with numbers below that necessarily can't conceive or that they can't have a child or anything. So
it only takes
it's
one
just
good one.
Yeah. It just gives us an understanding of what's going on.
Starting a family is one of life's greatest adventures, and Fertility Centers of Illinois is here to make it happen. With advanced fertility treatments, IVF refund options, and flexible payment plans, FCI makes care more accessible across Chicagoland. Summer's the perfect time to explore your options and make the most of your 2025 insurance benefits. Visit FCIonline.com to schedule your consultation, because your miracle is FCI's mission.
So, can we talk about the parts of the semen analysis that don't matter? Because we get a lot of this. Like, I think a lot of people realize, oh, these are the things that do matter, that count in the movement. Can we talk about the stuff that doesn't matter first?
Morphology. Let's talk about morphology.
Yeah, I was going to say
Might matter.
morphology.
What do you think?
Morphology is one of those things that is always emphasized. I think that it's probably the topic that I discuss the most in my consultations with patients, but I care about it the least. Yeah. So it just gives everyone so much anxiety. And I get that. Lots of times they're getting these reports. They see 1% normal. Are you kidding me? It's hard not to spiral in those sorts of situations.
So for our listeners, when we're talking about morphology, we're talking about the shape of the sperm. So both the sperm head as well as the sperm tail. Sam, what are some of the abnormalities that we can see in something like this?
Yeah. So basically when they're looking, they're going to see some sperm that maybe have large heads, short tails. Maybe they're missing what's called an acrosome, which is a little cap that's at the head of the sperm. And sometimes they're simply just saying head defect, mid-piece defect, tail defect. And so the amount of information that you're getting from a morphology assessment is going to be really pretty variable based off of the lab that you're going to as well.
And I'd like to make the point that on the criteria that most of us use, we would say 4% morphology is normal. And that means you can have 96% of your sperm being abnormally shaped, and that is still normal.
Yeah. And when I'm explaining this to my patients too, is that we're talking about these numbers, we're talking about their concentrations, their total motile counts and everything like that. When they're doing a morphology assessment, it's typically an assessment of about 200 sperm. That's about the amount. So it's simply a pretty small sample size of things.
So Sam, is it fair to say that in years past, we sort of said that morphology may have something to do with the sperm's ability to bind to and penetrate the egg? And are there any other tests now that we could do that might look at that in a better way?
Yeah, in the past, that was the understanding of why we emphasized it so much, is that we thought that it was about the ability to fertilize the egg. And it still may be so, but I think that the assessment that's on a semen analysis can't necessarily give us that information because it's such a small sample size. Now, with morphology, if I'm looking at it and thinking about it from an embryologist who's sitting there and looking at the full sperm sample, that's a different morphology assessment to me than like a strict morphology on a semen analysis. And I'm going to put a little bit more emphasis into that in terms of sperm quality. But in terms of other tests that people can do for fertilization capacity or things along those lines, we're trying to develop these sort of things that are clinically applicable. They're looking at things like CAP score. They're looking at things like PS Detect. That's one of the newer tests looking at phosphatidylserine. And so there's some of these things that are trying to understand the function of sperm rather than just is sperm there, is sperm moving, but not really knowing too much about it.
Is there a difference in what kind of results you get when you are getting an automated semen analysis, like one of the ones that comes through the big commercial labs versus one that's done typically by hand, or at least checked by hand by our urologists in fertility centers? What do you see as a difference? Because I see a difference between what I get and then what I get when we actually prepare it at our place for the IUI, and sometimes there are massive differences.
Yeah, and some of that could be just the natural variation between the sampling of what they looked at. I'm always going to trust a sample that's looked at by somebody a lot more. And if I'm getting a sample that's done by a big automated type thing, pretty much the first thing I'm going to do is get a sample that's done in our lab, because I know our technicians, I know what they're doing, I know the quality of a semen analysis that I'm going to get. And sometimes I think it's hard to explain to patients, why are we repeating a study that they have one of? But there is differences. That's good that they got that initial one. It gave us a screening mechanism. They found their way to me because they went through that process. But we need to dig a little bit deeper and get a little bit higher quality study.
As a corollary, what do you think about those semen analysis? And I've had several patients lately that will do their own, they'll do it via mail. They'll contact somebody through the internet and do it through mail. What do you think about those in terms of screening?
Yeah, I think it's great for screening. So I think that's the key. I think that there's two different types of direct-to-consumer semen analyses. There's the one that you can purchase. It's an app on your phone. You're getting the result there. those ones have quite a bit of limitations with them, whether it's the concentrations, whether they can say below this threshold of sperm, it's less than 5. Well, that makes a little bit of a difference, whether it's 0 or 3,000 or something along those lines. They might not be able to assess motility, different components of things, as well as you're leaving a lot in the patient's hands as to how they're doing and performing the actual tests too. So there's some variabilities that can come into play there. The patient is not counseled on, here's the steps that you need to do to make sure that this is done in the highest possible quality fashion. So those quality control measures. Now, I think the ones that are the mail-in type tests are a little bit better. For the most part, those are being run at high quality labs that do have measures of quality control and things. Yet there's still a lot of variables that I think are hard to really understand. For me, it's difficult to conceptualize how they can take this sample and they can mail it to somebody, then yet still get a real good motility assessment.
Yeah, I agree. Yeah.
And what is this being preserved in that they can run a DNA fragmentation test on, and I can still feel pretty comfortable about those results. So yeah, they hold a great spot in getting patients evaluated, especially the ones that maybe don't have access to care. There's a big areas of land that don't really have reproductive specialists. So there is a great role for those. But then I do think it's important for them to get a semen analysis done at a reproductive center.
What are some of the other components of a semen analysis that you don't put as much weight on?
Well, I think that's tricky because there can be scenarios where it's relevant to me, but other scenarios where maybe I'm not as concerned about it. And one thing I'll talk about is round cells in the sample. Round cells are a tricky thing because it might be immature sperm, which really don't have too many consequences to the reproductive potential of the sample. Or it could be inflammatory cells. It could be those leukocytes and such. And really a basic semen analysis can't differentiate those two things very well.
And what do you do with that? Because I think different urologists do different things. So what do you do if you see those round cells as opposed to what we might do?
So typically what I'm going to do is try to get a formal pyospermia stain, where they can tell me, is this truly leukocytes that we're seeing within the sample? Is it really evidence of inflammation? And then even if you get a result that says, yeah, it is inflammation, what do you even do with that? Because the data there is pretty inconclusive as to how does that actually impact outcomes. If it's a couple that is trying to conceive spontaneously, then I'm going to do everything that I can to try to remove a variable for them. Even if it's something that we're questionable about its true clinical impact, I'm going to try to do what I can. So I'm going to typically start with telling them, again, frequent ejaculation. And I'm going to talk to them about some antioxidants. There's some debate there. And that's where it's going to become my starting point. And then I typically start with NSAIDs.
I think for us, it may be a little bit different, or at least in our lab. If we see that, we really jump on and actually do a urine or a sperm culture, because if we're doing IUIs, intrauterine inseminations, and we're taking, so for our listeners that are listening, they may go, well, why did they do all this? But if we put sperm up inside the uterine cavity in an environment where there's no germs, and it turns out that there is an infection in the sperm, then we worry that we could get like a PID, a pelvic infection. So we tend to be a little bit more aggressive. But you didn't realize till fairly recently that I assume that the urologist did the same thing, but you guys don't. I just found out.
Yeah. I mean, for the most part, we're going to start with anti-inflammatories first. We're going to give a course of anti-inflammatories because typically it's an inflammatory in nature, not infectious in nature. But again, there's not a standard protocol for this. This isn't something that has a guidelines-based standard of care, a treatment assessment pathway. And there's so much of that within male reproductive medicine. There's so much that I think is driven by some degree of data, but how high quality, and a lot of it comes from expert opinion.
So when you're addressing it from the urologist perspective and you're using anti-inflammatories, are you using ibuprofen?
I usually will do something prescribed. So at times I'll use ibuprofen, but otherwise I'll use Celebrex a lot.
Okay. All right. And you would do that for how long?
2 to 4 weeks. And then I'm going to reassess the semen analysis, recheck to see if that's cleared.
And ejaculating every 2 to 5 days?
Yep.
Why Celebrex? Why do you choose Celebrex?
It's the anti-inflammatory that I've always used. And I don't know that I have a clear answer for that other than.
Okay. I mean, saying it's your favorite drug is a legit answer.
That's fair.
Yeah.
So tell us what you think when the semen analysis comes back and it says moderate debris on it. First of all, what is the debris? You got to figure nobody's dragging their penis through a trash can. That's not it.
Listen, I have seen a semen analysis that the read said there was carpet fibers in it before. So there can be all sorts of different things within a semen analysis. You never know. Yeah, I'm not exactly sure either, but it was very specific. It did say carpet fibers present. So
maybe they were telling you to clean the office extra hard that day.
Yeah, I could be.
No collection in the back of the car or something.
Well, typically, though, it's just going to be various amounts of cellular debris, dead cells. Sometimes there could be epithelial cells or things along those lines that just kind of accumulate and become a part of the cellular debris that's in there. It matters for me if the concentrations are low. Sometimes if there's an automated assessment of the concentrations, it might falsely say that the concentration of sperm is a little bit higher than it is. So I do pay attention to it in those scenarios.
However, our offices where we're doing more manual type of situation, that usually when we get debris, we shouldn't have to worry about it.
Right. Less significant in those instances where I'm typically not as concerned. Again, this just comes back to, again, I'm telling these guys frequent ejaculation. Make sure that you're moving this fluid through the reproductive tract. So and I'm talking to them about collection technique.
So this is not something we're recommending like penile exfoliation to get rid of dead cells is particularly necessary. We're talking more about the internal stuff that needs to get cleaned out, and frequent ejaculation will fix that rather than having to go get a facial for not your face.
Yeah, well, then I will say I'm also doing an exam in all my visits or all my initial visits as well. So I'm going to be aware if they have some real significant genital urinary eczema or something along those lines where I'm paying attention to those factors. Yeah.
So you've mentioned a couple of times collection technique. What are things that guys need to know when they're collecting to help us get a good specimen? Because I mean, if we don't get a good specimen, we're only as good as that is.
Exactly. And I tell them that it is awkward. There's no way around that. It's awkward. They're typically not going to get the normal sexual stimulation that they might get from a spontaneous sexual encounter. So it's going to be different. And so the first thing that I'm always telling them is just have that expectation and understand that that's okay, that we understand that it's not unique to them, that all of our patients, all guys who are having to go through this collection, that's a part of it. And then the other thing is the logistics of things. You tell a guy, okay, you have to masturbate into a cup. The guy's thinking in his mind, okay, I've got to go. I've got to masturbate into a cup. And then he's got to do that. And they're trying to hold the cup and everything. And I mean, it's not the easiest thing for a guy to do. So I also try to explain to them with that too, that, hey, listen, this might be a little bit tricky. Try to do the best that you can to collect. And then not using lubricants or anything along those lines for the collection, trying to get a time period of absence that's accurate beforehand. I tell them again about 2 to 5 days. I tend to favor the 2 to 3 day abstinence period for collection. And then when you're transporting it, trying to keep it at body temperature, collecting at home and bringing it in, making sure that you're doing that you're not, trying to get the sample as far away from you as possible during the time period that you're transporting it, that you're not leaving it in the trunk of your car for an hour while you run an errand or those sorts of things.
Coming from a different geography than you, but we're always like, don't stick it in front of the air conditioner and don't put it on the
People always think it needs to be on ice. And we're like, no, it doesn't need to be on ice.
Yeah. Yeah. People always want, I agree. People always want to ice their specimen.
But don't put it on your heated seat in the car seat next to you either.
Yeah. Exactly.
It likes body temperature.
Yep. And so trying to do those sorts of things to put them at ease, to understand that other guys struggle with this and it can be challenging for other people too. I think helps guys just relax a little bit.
Yeah.
And so that for me is one thing that I'm talking about when I'm having my initial consultation, talking about how we're going to get a repeat semen analysis and different things that they might be able to do to help improve the sample. The big thing I see from the first semen analysis is almost always the volume is reduced. Again, not necessarily just because they lost some specimen, but because maybe they're uncomfortable, they're not getting that normal sexual stimulation, those sorts of things.
But guys, if you lose volume, let us know. Don't be embarrassed by it because that can affect, we're like, why is his volume so low? And so make sure you let somebody know if you don't collect your full sample. in the cup.
Why it's important is because when we come into our appointment with you and we've looked at your semen analysis and we're like, we're really concerned, versus if it's a semen analysis and it says he
Missed the cup,
missed part of the ejaculate, like we're a lot less concerned and worried, and we're going to be like, okay, well, these are things that can be affected by having missed the cup. These are things that shouldn't have been affected by missing the cup. So maybe we need to repeat, or maybe we not need to repeat, but that is so important.
Yeah, there's a lot of things with volume that relate to my differential when I'm talking about a patient too. Like that's a big component of my evaluation of patients. So when we're talking about things that aren't very important, volume is something that for me is very.
So what are the other things that can affect volume?
Well, I mean, an obstruction. So if they have an obstruction somewhere, so some guys can have it where everything is completely obstructed at the level of maybe the testicle. Those guys are still going to produce some fluid. It's not like everything's going to be absent. The fluid is going to be coming from the prostate and the seminal vesicles. They can have retrograde ejaculation, so it can be going in the backwards direction. They could have an absence of one testicle or one vas deferens. So maybe they're only getting contributions from really one side. So different things there too.
Medications that have an effect on volume?
Yeah. I mean, the big one as a urologist is the prostate medications. So things like tamsulosin, which is an alpha blocker, one of the major side effects of that is retrograde ejaculation. And so getting guys off of certain medications, because again, that's a medication that's in my wheelhouse as a urologist. So that's one thing where I feel comfortable about making changes in medications, is something that is maybe a little bit more favorable, has less of that side effect, maybe changing them from an alpha blocker to something like a daily tadalafil, which can have some improvement of urinary symptoms and things like that as well, but doesn't have the side effects. So we can change medications. Additionally, medications that can manipulate some aspects of the hormonal axis. So things like finasteride and such, which we see so many guys using because it's readily available, especially through various mail order avenues and things like that.
Other components of the semen analysis that you do find is very important.
Wait, I have one quick question before we leave the volume issue. Does dehydration have any impact on that? Because in Vegas,
guys in Las Vegas,
especially this time of year, like, people ask me that all the time. Does dehydration have any impact on it?
Yeah, I do see some changes with it. So if a guy is pretty, dried out, they're going to maybe see some reduced ejaculates and everything. If the dehydration is from a night out where they've had some fun and everything, there's a lot of variables there, just the dehydration. So a lot of things can be coming into play.
Thank you. Okay. So back to other important parts of the semen analysis.
So obviously concentration. I don't know how much we need to talk about that one.
Right. So concentration is important. Concentration is one of those big ones that if you miss the cup, that can have a huge effect, right? Because you have the highest concentration at the beginning of the ejaculate.
Oh, okay.
Very good. And then motility. Talk a little bit about progressive motility.
Yeah, I have questions about motility for sure.
Yeah, usually for like a calculation of a total motile count, we're primarily using total motility. But I'm always paying attention to progressive motility if the couple is actively trying to conceive through methods other than in vitro fertilization, essentially. Because if they are trying to conceive through IUI or spontaneously conceive, timed intercourse, those avenues, they need that sperm to be moving. They need it to find its way. They need it to go and get that egg to fertilize. So progressive motility matters. You don't want something that's just sitting there twitching. But then you're going to look at some of those variables like, hey, how long ago did they collect this? How did they transport it? Confirming that they didn't use any spermatotoxic lubricants or anything like that. So you'll check in on those variables if you're seeing that reduced. Now, if they're trying to conceive through something like IVF with ICSI, well, motility isn't as important in those instances. Essentially, it's a surrogate of viability. Mm-hmm. If a sperm is moving, it's alive. And so then they're able to use that for the insemination. So for me, the progressive motility maybe doesn't matter so much in that instance as it does for the other avenues of trying to conceive.
So then you must be glad that the WHO breaks it down now into like motility, progressive motility. There's like 4 different categories. And used to it was just either modal or non-modal. And that, I will say, that made it much easier as a physician to explain to people, oh yeah, this sperm's moving, this sperm's not. But it's
I'm
confusing now.
I'm really only focusing in my discussion with the patients about total motility and then progressive motility. I'll have conversations about that. But the other factors, and like they say, some slightly twitching, I tell patients that, hey, listen, we know that it's alive. It's helping us with understanding viability. But I don't spend the time with big discussions there unless I get specific questions about it.
What are other parts of the semen analysis that you have strong feelings one way or the other about?
Well, now we're going to get back to morphology. Yeah, I mean, again, we hit on morphology a little bit earlier, and it's just one of those factors that I feel like the more that we learn about it, the less important it's become, because it's just not, the data is just not showing that from a strict morphology assessment on a semen analysis. It's just not correlating with the reproductive outcomes, things that matter, the fertilization rates, the pregnancy rates, the live birth rates, things along those lines. It's not dictating which avenue of reproductive care we might go down in most instances. Now, traditional IVF versus ICSI, sure, maybe you're going to make some decisions based off of morphology, and everyone's practices and how they approach morphology is a little bit different. But I'd say from a reproductive urology standpoint, I think there's less and less relevance with it.
Awesome. One less thing for us to have to think about in
Yeah.
a, oh my gosh, freak out kind of way.
Right. And I always emphasize abnormal shaped sperm does not mean abnormal
Normal
shaped
babies.
child.
Oh, yeah. That was genetics. Yeah. That
Yes.
has to do with the genetics. Yeah.
Yeah. Because that is, I mean, that
That's
is what
huge.
everyone comes in scared about.
Yes.
Everyone is scared about that.
So I have a question regarding timing of a semen analysis, not necessarily since last time you've ejaculated, but when should a guy have a semen analysis completed? So we have lots of people who come into our clinic and they're like, the ladies are like, oh, we just need to check me out because he's had kids before. I know it's not him. Which of the guys need to give their little specimen in the cup?
All of them. That's what my answer is it doesn't matter if somebody's had a child before. Things happen through life. Things change for various reasons. Somebody might have a varicocele where they're seeing a deterioration in semen parameters. There might be some epigenetic component of thing that's triggered and that their gene expression has changed and now they're seeing a reduction of spermatogenesis. So there's a lot of things that can change over the course of time. So if you're getting an evaluation, I mean, the evaluation should be in parallel. A semen analysis, yes, it's awkward. Yes, it's maybe for whatever reason, maybe a little bit embarrassing to have to be doing that, to hand over a cup, but it's a pretty straightforward, easy test that gives us a lot of information. So it helps us understand the starting point of things. So for me, that is a very, very easy answer. I would love it if that was the first step along with whatever the first step might be on the female side of care as well.
So Sam, I don't want to end this without asking this most important question, because this is a question I get a lot. How strongly do you feel about agglutination? Is that a big problem or not?
In most instances, I really don't care about it too much.
Okay. I don't either, but I just wanted to make sure you didn't.
Yeah.
Especially liquefaction time, as long as we're talking about the random things.
Yeah. Not too concerned there. Agglutination, especially again, if they're going through a process where they're getting semen processing, it's not going to really hold much relevance at all. If the lab is coming to me saying, hey, listen, the sample, we're having a lot of problems with it, that's when it matters to me more.
If it's like Jell-O, you need to worry about it, but otherwise, not so much.
Right. Yeah. It's usually, and especially too if motility is maintained. If they've got agglutination, but they're still producing good motility percentages and stuff, I certainly don't matter about it too much. Now, if they have a bunch of agglutination and they have 2% motility, sure, we might look into things a little bit more. We might look into anti-sperm antibodies, something along those lines. But for the most part, those instances are pretty rare.
So I have a series of questions that I'm going to ask you of, does it matter or not? We don't need in depth because otherwise we'll be here the rest of the day.
Yes or no? Is that good?
Yeah.
Just yes or no?
Just yes or no.
Okay.
Boxers versus briefs. Do they matter? Biking a lot. Does it matter?
Can I answer you beyond yes or no? Depends on the time. It depends on the time of how they're riding. I tell guys limit it to an hour.
Okay. Do the bike seats make a difference? Because they've got some that have more space in the...
Not too much. A lot of that's about pressure on the perineum, and they can get numbness, but not necessarily as much of a concern for me for sperm production, more about sexual function.
Hot tubs, or really being immersed in really hot water, whether it's a bathtub or a hot tub.
Yes, that does matter.
Saunas?
Yes, matters.
Okay. Working outside in perhaps Las Vegas heat in July with an outdoor job. I get this one all the time.
I do too.
Honestly, I don't too much in Chicago, but I would say yes for that. I mean, I'll compare it to firemen. They have a lot of heavy equipment, warm temperatures and stuff. And I think that it can matter to a certain degree. The problem is it's a variable that probably can't do much to change.
Computers on your lap.
No, I'm not too concerned about that.
Cell phones.
Martians.
Yes. That's going back to Las Vegas there and then Nevada.
I was going to say, if they had a heavy night drinking last night.
Yes.
Okay.
Just heavy night drinking in general. If you're going through this process, I tell guys avoid binge drinking. I'm not saying you can't drink. I'm not saying complete abstinence or anything like that.
Smoking medicinal marijuana.
Marijuana use.
Yes, if it's daily. If it's a couple times a week, I'm less concerned.
Nicotine?
Yes. I'm typically more concerned about nicotine than I am about marijuana.
Vaping? Okay. So it's the nicotine. It's not necessarily the cigarette.
Right. Pouches, Zins, those sort of things. Not good too.
Okay. Thank you.
Sorry. All right.
I think that's a great way to wrap up this episode. And Sam, it has been so much fun having you. We definitely
I know. You need to come back again. We can think of some other topics.
Hey, yeah, this is the best part. I love saying this is kind of what I talk about in a consult. So I like having these conversations. And I have a fellow and I always tell him my favorite thing to do every day is just sit and talk about reproductive medicine because it's so much fun and there's so much we still have to learn.
That's right.
And figure out too.
Yeah.
I always think it's fun when you have reproductive urologists and reproductive endocrinologists get together. I mean, honestly, it's one of my favorite things at ASRM, our national meetings, because we get to talk about things that, we kind of assume this, you kind of assume this, and we put them all together. And it's like, maybe we should do something. It's good.
Yeah. And I love it because where I practice at Fertility Centers of Illinois, I'm integrated into a reproductive endocrinology clinic. And so, my colleagues are right next door to me. So every single day that I'm in office, I'm having these conversations. If people are at a different office, I get text messages and phone calls. And I love it. I mean, that collaborative care component it's truly, truly awesome.
That's
to say professionally, outside of the people in my practice and these two lovely ladies, probably the most text messages go between me and my reproductive urologist colleagues.
Yeah.
Well, good. That's a good thing.
It is a good thing. It is a good thing. Well, thank you again for joining us. And thank you to our audience for listening and subscribing to Apple Podcasts. And we want you to get next Tuesday's episode to pop up automatically. And be sure to subscribe to YouTube. That really helps us spread reliable information and help as many people as possible.
Right, thank you, guys.
FertilityDocsUncensored.com to submit questions and sign up for our email list. Keep an eye out for our book that's being released September 3rd and get your pre-orders in now.
And as always, this podcast is intended for entertainment. It's not a substitute for medical advice from your own physician. See you guys later. Bye.
This podcast is sponsored by Receptiva Diagnostics. Receptiva Diagnostics is a powerful test that can help detect inflammatory conditions on the uterine lining that might be preventing you from becoming pregnant or staying pregnant. If you have experienced implantation failure or recurrent pregnancy loss, ask your doctor about Receptiva Diagnostics testing. If found, uterine inflammation can be treated, providing a new pathway to achieving a successful pregnancy. Receptiva Diagnostics, because the journey is worth it.